I got really sick when I was pregnant. Like, I was dying. I was like, my husband's like taking my clothes and I'm like, he's been asking me like, sure, he asks me every day too. Then I have to do that. Because it's literally everywhere. And his ears. It was like he was wearing a onesie from his diaper in the back. Oh, what's that? El Chihuahua?
Like, what it is.
What does it what?
Oh, what kind of cost?
Yeah. Yeah.
What can they cost?
Not viruses, so it's not, development. Developmental. Text through
Oh, you like the definition?
No, but. Therapeutic index is therapy.
Birth defects caused by chapter.
Do you look up Carson's?
Yeah. And then,
Are one or something.
Other than drop.
the 80-20 rule.
Okay, go ahead.
So carcinogenic drugs are Humira, HUMIRA.
Okay, continue.
Alright, then you have Anglo,
Sorry, EM is on top. Oh,
So they all have this.
Prednisone is generally like anything swells up stress.
All of them.
Yeah, so this does the immune system and
I'm just gonna put
I don't know about this.
like artery.
There are examples for when like
inflammatory.
therapeutic cells by-
Does this suppress the immune system? Yes, suppress the immune system. Because that's how you
for, yeah, for a low.
suppress the immune system
High therapeutic effects.
and treat inflammatory conditions
It says it's already associated with events.
like heart rate.
I think it's C. CROH and S.
I have spelling issues.
UN. That's how it was on Google.
And there's like all kinds of top three cancers.
Do you know how to get that one like the same size as that? I can't bring it over to the end. I tried at first to just put it underneath the other one. And I was like, what the heck? I don't do it enough to.
And I can't get it all over. I made it just inside.
Oh, I like it too.
It won't go all the way over. I gotta see this meat, which is my size, but.
As long as we can like, no, I don't understand. Yeah, I can change the size, but I'm not.
Yeah.
Broccoli actually has a so eat broccoli.
Eat more. So when we're done with our slide, what do we do?
Is there a way to upload it to your group, or you can just email it to me in Canvas? Either way.
Just
Easier way to go.
I'm not very sticky at all.
save it to your desktop. and
Yes,
email.
there you go. Look at that. Listen to the master. Save it
Usually
to
when
your
I have, like,
desktop.
Yeah.
Text from my call my sister and I'm like, help.
What's her number?
No, I call my daughter.
You said we pronounce your name?
Cardinal. It's Peruvian, so.
Peruvian. Okay.
Yeah.
All right.
We
So,
say, we say the way it actually tells me to.
yeah, I know, I didn't want to mess that up,
That's
so.
all
So therefore, Dr. Carter, with regards to the NCLEX questions, on the thing that says take a screenshot, or do you want a PDF there to? It doesn't
Anyway,
matter.
I've had both submitted before.
Okay.
Like there's one that's the master,
Yeah,
in the
it
example
shows
like
the whole
that,
thing.
shows like each time you took it and what you, how
Right,
many you did, or just the PDF. I don't care. It's just has to show the date and the score.
Just do it, I use it up for
If
safety
you
as
go to,
well.
it's like, it's perfect, so he's not from the state.
yeah, that's how it usually does.
Yeah.
So,
Whatever, I'm just trying to give you options.
sure, I just wasn't, I didn't, I've never done the screenshot before. So.
You get to learn a new skill.
No, I know how to do it.
Oh.
What I was saying was,
Never
I had
submitted
never
one.
submitted it, because the last classes we did, there's just the PDF.
I just make stuff up. So.
Okay, so however you want.
I know, I'm just trying to like give options. You can submit it either way. I don't care.
Okay.
Yeah. Whatever makes you happy.
Thanks.
Have you ever heard of magnesium giving people nightmares? Like if had too much magnesium,
But that doesn't mean that
could it be a side effect of it, the magnesium?
it wouldn't be a common one. Yeah, probably
A
common.
lot of people do that to their kids, and I'm like, it's gonna make your kids.
There's been an
worse.
FDA warning about that. In fact.
Oh, really?
People give their kids halitosis.
Well, maybe
Dude, this is not like giving your child a glass of water. This is
Yeah.
Oh my goodness, it's gonna affect their natural ability to go to sleep on their own.
necessarily, it's just any time you're putting a substance into your body that's not intended for you, you're subject to adverse effects.
Okay, yeah, you're. I believe you.
So if you can either email it to me or whatever by 9 o'clock, then you can take a break, come back like 10 after, and we'll start with these. Did you guys email it to me or? Did you email it to me or? Okay. Okay, sounds good. Do you understand what that was?
I understand.
Well, it can actually be both, but in general, yeah, you can have a, it depends on if the drug, if you're
Yeah, I just need to
metabolizing the
know
drug
it.
as inactive, or if you're metabolizing the drug as more active. That's what we talked about. The drug. So, prodrug, when you metabolize. But most drugs are deactivated, so if you don't have the ability to deactivate the drug, you're getting more active drug, right? Super therapeutic. You get trouble.
Email should be in a module, right?
It should just be in the, go to your inbox and,
Do you want me to just inbox it to you?
yeah, just in the regular inbox, attach. Everybody emailed it?
No, I'm still
Oh,
working
okay.
on it.
Yeah, just email it and take a break, stretch your legs, have a beer.
Yes. That's exactly.
9 o'clock in the morning.
Time has no meaning.
It's 5 o'clock somewhere.
Human made calendar.
Okay, I sent it.
Awesome.
Oh. Okay, now it's sent.
Yeah. You can just do it through Canvas, right? Email it.
Oh, I'm just doing it directly from our.
Oh. You're being all
You're fancy.
fancy. That's pretty
I
fancy.
didn't do that. Didn't know you could do that.
Yeah, usually it'll open up the wrong email for me because I haven't figured out how to change my settings to the email that I want. All right,
There's so many different technical obstacles.
it really is. All right, I got agonist versus antagonist.
Oh, this. Sorry. I don't know. In the same thing.
All right, I got group 4 and group 3.
What is your email? It's not showing up on Canvas.
Just do the Canvas inbox.
No. When it's in.
Elizabeth dot Cardenas at Fortis College dot edu.
Got it.
Refuses to be defeated.
Right.
That's, it's a good trait. Don't be beat by technology.
I didn't even have time to copy and make a copy.
Mary appreciates it.
I do.
Oh, okay, all right. Fixing your address. Yeah, yeah.
We'll figure it out.
Yeah, I was checking that online. Back in the license online.
I was just gonna make sure you knew I was here. It's just after this.
No, you gotta tell me otherwise.
No worries.
I will. Agonist, antagonist, we've got.
No, wow. My niece is getting married. And then so I have to do my niece's hair today, my sister's lashes tomorrow, my other niece's hair tomorrow.
I feel like you don't mind.
Oh, you did it last, wait, what?
For
Kyle? Hey, what? When do you go to work?
I only have 2 groups of PowerPoints.
You have mine? Did you say 5?
I have teratogenic and carcinogenic, and I have agonist and antagonist.
You don't have our own?
I emailed it to you in the Outlook.
Let me check and see if it just took a minute to come, maybe.
Sierra's. I guess I don't know, I just named mine group 5, so I don't know.
Do you just want us to send it to your email?
It's fine, yeah, either in Canvas or via.
Send it to her for Canvas.
Dr. Carter? Yeah. Jerry, unlock the PowerPoint for. It says the file is locked.
Well, because I was still doing something, let's check. And I have it showing as available. So, not sure.
Second. Yeah. It says file is locked until April 13th.
Let's refresh here. See what's going on.
Or you can just like.
Yeah.
Oh, okay, let's see. All right, it's published. I was looking in last terms. All right, I don't think I got everyone's slide still. Which way did you send it? No. I only have agonist, antagonist, and teratogenic group 3 and 4. And it could be just be because Microsoft Outlook likes to filter things. Can you send it through Canvas? Go to the Canvas course where it says inbox. And then you choose the little pencil to compose a new message. Then you select the course. I only have those 2 PowerPoints.
Oh, no, I know. No.
No room for error.
Where you go send your professor a message. In the bottom left hand corner, there's a little like you can look.
Got that.
So in case you don't know how to do it in Canvas, you go to your inbox, right? And you click the little pencil to create a message and you select your course. And then you choose the person from the drop-down menu. And then you attach with the little paper clip down here.
I left like the same.
Yeah, ELIZABECH.CARTEMAS@FortisCollege.edu. If you're sending it that way, it's just easier to send it through Canvas.
Well, I'll just know that I have 10 to 7. So I can, 4 times 2 minutes, 30 seconds. So he's covered in dirt, so he strapped him in that. But I put him in that.
So I still don't have group 1, 2, and 5.
I'm trying.
I got 3 and 4.
Literally strapped him in that. So I strapped him in there.
How did group 1 send it? Okay. How did group 2 send it? Canvas or Outlook? Group 2 sent it Outlook,
Yeah. I'm doing it right now.
and group 5? I got agonist, antagonist, teratogenic, and carcinogenic. So 3 and 4. Just waiting. All right, we got group 1. Got group 1. Let's see, we got both ways. We got group 1.
Okay. What? Oh.
Waiting for group 2 and group 5. Group 2 and group 5. Still trying to find what?
Where it saves it.
Oh, you tell it where it's saved.
I did.
More than once, that's okay. Just know that there's a. What group were you? 5? Who's group 1? Oh, we got group 1. Who's group 2? Did you save it? You're sending it out or yeah, the outlook is slow. Okay. Yep. There's Mares. All right, while we wait for that, let's group one was adverse drug event versus idiosyncratic. Group 4, group 5. Agonist, antagonist. Group 1. Is this group 1? All right, group 1. Who would love to be our designated speaker? We've got. Yeah, I can do that. Sorry. I'm a light lover. Come tell us about the difference between an idiosyncratic reaction and an adverse drug event. Yep. You get to stand up and tell us. Okay. Thanks. And then I'll just scroll this down after.
Okay, so the idiosyncratic reactions are going to be basically incompatibility with the meds. So one person can do well with meds where the other one won't do well because of genes or blood, their blood, or different types of examples, but you're going to do the harmful and fatal appear to be in low doses. And then thrombocytopenia and polythene, if I even got those right. So it's just an abnormal and unexpected response. That's going to, you could get an allergic reaction. So again, if someone is taking the medicine, you have two people, one's taking it and it does very well for them, and then the other does not do as well.
Okay, and it just an idiosyncratic is different than an allergic reaction. Allergic reaction involves our immune system, or then an adverse drug event.
Okay, so there's going to be external and internal for adverse drug event. External is going to be like your caregiver or patient or even medical equipment malfunctioning. So that's going to be external. Internal is going to be like self-induced. So if you're drinking alcohol to take your pills, that's not ever going to go well for you, and that's going to be internal. But it's any undesirable outcome related to administering or failing to administer prescribed medication.
Okay, thank you. So yeah, so an idiosyncratic reaction, we had just briefly mentioned on a slide where it's not an expected reaction, right? It's just something out of the blue. It's not in the drug book. It's not even listed under the, the less common drug reactions. It's something very particular to that person and either their genetic makeup. They may be lacking an enzyme in order to metabolize a drug. So they have some buildup, or they just may, because their bodies built differently, respond in this unusual way. Where an adverse drug event is typically the effect of the drug that's undesired. Remember, we said there's the effect of the drug that is desired, but there's the effect of the drug that's undesired. It's all the effect of the drug, but whether you desire it or not is kind of determines whether it's an adverse drug or a reaction or a side effect, as they call it. So if you take a drug that helps you sleep, like you take Benadryl diphenhydramine, and that's the active ingredient in your sleeping pill, well, that's the benefit. Taking it for that purpose, the side effect or the adverse drug effect is going to be that you may have morning time sedation, that you may have dry mouth, that you may have constipation, that you may have lightheadedness. So those are, but if you take the same drug and you're taking it for, because you have overactive bowels and you're taking it to slow your bowels, would be an unusual use. But then the side effects now are causing you to be sleepy and having a dry mouth, but the therapeutic effect would be that your bowels slow down. So it's all in just in the perspective of how you're using it, right? So adverse drug reactions are expected. All right, I got two. Let's see, right here. Yes. You knew you sent it. It was just Canvas is slow, filtering out. I don't know what they're worried about, but gonna hack into your grades and give you all A's. Something like that.
I also sent it on Canvas.
Awesome. Way to double do it. Yeah, it's just super. There we go. All right. We've got additive versus synergistic.
What is this?
Sit.
It might have been in the template or something. Who
Yeah.
knows? All right, there's group 2.
Okay, so the definition of synergistic effects is drug interactions in which the effect of the combination of 2 or more drugs instead of drugs with similar actions and greater than the sum of the individual effects of the same drug given alone. So, example, 1 + 1 is greater than 2. And this is an example. Carbon tetrachloride and ethanol are individually toxic to the liver, but together they produce much more liver injury than the sum of their individual effects. So they both are bad for your liver, but together it can be worse. This occurs when 2 drugs administered together interact in such a way that their combined reactions, you know what that means? Are greater than the sum of the effect for each drug given alone.
That
Right here. Combined reactions or and?
looks like function to me.
Oh yeah, combined function. Yes, it is.
Somebody's taken calculus before. Yeah.
So, and even if like on the opposite, if you take 2 together, they can be more beneficial in some
True. True,
cases.
and that's sometimes how we do it in medicine is we take 2 of a lower dose together to get more bang for the buck.
Yeah.
All right, and then
So
additive.
Additive effects are drug interactions in which the effect of a combination of 2 or more drugs with similar actions is equivalent to the sum of the individual effect of the same drug given alone. So often drugs are used together for their additive effects so that smaller doses, like she said, are given. Smaller doses of each drug taken can be given to get a more beneficial result. Example, 1 + 1 = 2, and then aspirin and Motrin together would give the same benefits of both pain medications as they would taken separately.
Right, perfect. Great, so additive is very much like we're saying. The sum of the 2 drugs put together. If you take, I mean, generally we wouldn't recommend taking aspirin and Motrin together, or maybe you would use Tylenol and Motrin, and you get the benefit of the normal benefit of Tylenol and the normal benefit of Motrin. That's what we do sometimes in pain control, rather than giving a high dose of one. We'll just say, oh, take 2 Tylenol and 2 ibuprofen and call me in the morning. Where synergistic is both potentially beneficial but potentially harmful. So what if you take your diphenhydramine, which is Benadryl, and this is in your it's your sleep medication called Zzz. It's an over-the-counter product, and you wash it down with a nice glass of wine.
Perfect
Yeah.
combination.
Now we're talking. Well, this will have a central nervous system depressant effect, and this has a central nervous system depressant effect. However, the 2 of them together are not 1 + 1 = 2. It's more like 1 + 1 = 5, right? You get a whole lot more bang than you were intending. So sometimes it's something that we want, and sometimes it's something that we don't want, and our patients are not aware of it. They're just thinking, well, both of them will help me sleep, so this is going to be a good thing. That's why you, as the nurse, are going to be aware of that and provide that education. Because now you are the expert on it. You've taken this course and you now know. All right, group 3 was this one, right? Slideshow. All right. All right, let's talk about an agonist.
Okay, so we just liked to keep it simple, so we just kind of went with some more
Yeah,
basic.
I like
definitions.
simple.
Okay, so an agonist is a substance that binds to a receptor and causes a response to the intended chemical and receptor. So an example of an agonist would be things like an opioid, like hydrocodons. Those are mild agonists, and then opioids like morphine and fentanyl are strong agonists. And so they bind to receptors causing respiratory depression and analgesic effects. That's kind of short and simple
Right.
idea of an agonist. And then an antagonist, it binds to the receptor and blocks the activation of certain receptors on cells, preventing a response as it stops the effect of another substance. So it binds to a pain receptor, but it does not reduce the pain signals, just blocks them in a way so you can't feel them. So an example of this is naloxone. I think I'm saying that right. It's
Yep.
an antagonist because it can quickly block the response of an opioid overdose. I don't know why that's so hard to say.
It's just a bunch of words, long words. Perfect.
And then the book also gave mixed and partial agonists. So that binds to a pain receptor and causes a weaker pain response than it would if it was a full agonist. And then it just referred to this being useful in pain management for OB patients because it avoids oversedation of the mother and or fetus.
Okay, that's a good use. Excellent. All right, so this is the basics of how drugs work. They are oftentimes an agonist. So we are wanting to elicit a response. We want to make the body do what it's normally programmed to do. So we're taking a drug that kicks it in the groin and makes it do it more, right? So that's an agonist. It pushes a normal body process forward, or a normal chemical reaction forward, or a normal neurotransmitter response forward. And the opposite of obviously is the antagonist, something that is going to block that. Some of the drugs that we take are antagonists. You mentioned a great one, naloxone. Narcan is the antagonist to an opioid because it blocks the receptors where the opioid normally bind for their activity. So agonist and antagonist. Sometimes we'll talk about in your book on page 26, there is a drug receptor interactions, competitive antagonist, non-competitive. We may mention those things some, but mostly we're going to stick with agonist and antagonist. All right. Let's see what sweet group number 4 had to say. And sorry, your format got lost in when it came over. Group 4, be brave. Be brave.
Okay, so we had tetragenic and carcinogenic. So tetragenic is what drugs that the mom should take when she's pregnant, because they can go through the umbilical cord through the placenta and cause birth defects in the baby. We found sulfamides, which are antibiotics, can cause that, and they can cause heart defects, pyloric stenosis, brain defects, hearing loss, and hypoplasia in the baby. This usually happens between week 3 and month 3 in pregnancy. And then drug-induced carcinogenic causes cancer. Some drugs include Humira, Engro, Remicide, and Yeah, prednisone, and it suppresses the immune system to treat inflammatory conditions like rheumatoid arthritis and Crohn's.
Great.
Causes cancer.
Yeah.
So
Thank you.
question, because you know I have Crohn's disease and I am on Humira,
Mhm.
so I am a higher risk for cancer.
Right, so the purpose of these particular drugs, thank you, is to suppress our own immune system. Like Crohn's and rheumatoid arthritis are autoimmune diseases where your body doesn't recognize self. So you take some form of a drug that will calm down this response. Unfortunately, our immune system is key in suppressing cancer growth. We have constant hits to our DNA from everything that we're exposed to in our environment, the toxins that we eat, the microplastics in our food, we're constantly exposing our bodies, our DNA to teratogenic or cancer-causing effects, viruses, bacteria. And luckily, we have an immune system that tamps that down. So when we monkey with the immune system and we are suppressing the immune system, then we have less control of keeping those accumulated effects of our life, keeping those cancer-causing cancer cells that develop in check. So you're at higher risk for developing a cancer. They are not necessarily cancer-inducing. So a cancer-inducing drug is a drug that you take that the drug itself is inducing a cancer. This one is just suppressing our immune system, the examples that were given, and our body can no longer control our own cancer growth. So yeah, and there's lots of drugs that are teratogenic. The whole field of pregnancy is a specialty. So if you ever get a question about a drug and one of the options is like a woman who's pregnant, just always know you have to always look up a drug before you give it to any pregnant woman, because there's so many, and so many of them, we know are going to have harmful effects, or we are sure, we theorize based on animal studies that they might have harmful effects. So a smart nurse, if you're not 100% certain and you know that your patient is pregnant, is looking things up, double checking, right? All right, carcinogenic and teratogenic. And group 5, last but certainly not least, tell us about peak levels. Woo, woo, look at that.
Nobody else wants to get
I know, you gotta be brave. We're all friends here. Nobody's judging. We're just all learning together. Don't worry. All right.
So the basic definition is highest levels of medication in the blood.
Excellent.
But the book says drug's peak effect is the time required for a drug to reach its maximum therapeutic response. Physiologically, this corresponds to increasing drug concentrations at the site of action.
Yeah, makes sense. The more drug you have, the higher the peak. Let's see.
Trough levels, which is a weird side note, when I typed that in, I got a picture of a goat, but like not that kind of trough. Okay, it is the length of time until the onset of peak and peak of action, and the duration of action play an important part in determining the peak level and trough levels of a drug. If the peak blood level is too high, then drug toxicity may occur.
Yep. Exactly. So thank you. So peak and trough are pretty important concepts. Oh, you have another one? I apologize. Tell me. There we go. Therapeutic index. I forgot.
The range of doses at which medication is effective without unacceptable adverse events. Therapeutic drug monitoring and peak and trough values are measured to verify adequate drug exposure, maximize therapeutic effects, and minimize drug toxicity. This monitoring is often carried out by clinical pharmacists. A positive change in a faulty physiologic system is called a therapeutic effect of a drug. Such an effect is the goal of a drug therapy. So you always want to say like in the therapeutic range, or else you got to start all over again.
Or you got to correct it one way or
Yes.
another, right? Thank you. So let's go back to peak level. So if you remember our little, the time, here's the time to the minimum required concentration to get an effect. And here's the level at which here's where you're going to have toxic effects. Here's the minimum therapeutic. So you had that. Right. So obviously this is your peak, right? And obviously down here is your trough. So generally, drug like vancomycin, which is an IV antibiotic, it's a pretty hefty thing, only given in inpatient setting. Typically the nurse will be drawing peak and trough because we're trying to make sure that they stay within that therapeutic window in there, right? And you don't want to have a toxic effect, and you don't want to, if they're going to have the antibiotic, they might as well be taking it and have it in the therapeutic window. And the problem comes when this therapeutic window is very small. Like some drugs have a really wide therapeutic index, this therapeutic window. And if you're a little over, it's not toxic, but some have a very narrow one. So they chose a great concept of Coumadin, which is warfarin, which is that anticoagulant people are given to prevent DVTs or PEs. And it has a very narrow therapeutic window. And so it's really small. This one, the therapeutic window is anywhere from 2.0 to 3.5. And we'll learn about this when we get to anticoagulation. But this is really a small window to stay in. So people who are on this particular medicine, especially when they're starting or making dose changes, have to get checked very frequently because we have a hard time predicting whether a dose will send them way up here or a dose will send them here. So knowing the concept of peak and trough, and then the therapeutic window, the therapeutic index, and what a narrow therapeutic index is. Yeah.
So if they're taking the medicine at home, do they just get checked when they go, like, how do they check their therapeutic index at home?
So, well, something like Coumadin, it doesn't typically get checked at home.
Yeah.
So usually it's a lab draw. They will, in the hospital, it'd be a lab draw, right? You're checking to make sure when they have reached the therapeutic level. Oftentimes in the doctor's office or in an outpatient setting, there is a machine that's very much like a glucometer, but can give you the number right there on the spot. People who have had orthopedic surgeries and have gone home, and perhaps they have home care to assist them with managing their Coumadin, and they might have a therapist. Oftentimes the home care nurse has a portable machine or is drawing the lab. Generally, once a patient is stable, they're only checked maybe once a month, or even less often unless they're ill or have med changes. It's not our favorite drug, but it is effective.
So let's just say ibuprofen, like that has a bigger therapeutic window because they say every 4 to 6 hours. So
Yeah.
people get like at the 4-hour mark,
Yeah.
at the 6-hour mark.
Yeah, because you can have a dose of ibuprofen the over-the-counter dose is 400 milligrams, which is 2 of the 200 milligram tablets, but the prescription dose is often 600 or 800 milligrams, right? So that's a pretty big difference. That's, you can take it, it's usually 3 times a day. And that's a big difference. That's a 100% increase. That's a big window so you could take 200, or most people don't get a therapeutic response from 200.
Does the therapeutic index change with the amount of medication? Like if you take 400 ibuprofen versus 800?
No, the therapeutic index is defined by what drug it is. Each drug has a different therapeutic index. Some drugs, need a concentration way up here to begin to have the effect of the drug, while others are down here. The therapeutic index is specific for the drug.
But could it change based on the patient? How the drug is working?
Well, I mean, there are variables for everyone.
Yeah.
So there are exceptions to every rule. But for this particular concept, we're just sticking with the basic idea that, you know, a therapeutic index is defined by the drug. A narrow therapeutic index is a more dangerous drug because we have to keep it within such a small range, and going over, you start to begin to have toxic effects. Where something that has a very wide therapeutic index is more likely to be a safer drug, is more likely to be an over-the-counter medication. The FDA has determined, all right, most reasonable people can take this safely. How we ended up getting so many prescription drugs to be over-the-counter. You know, like Aleve used to be prescription, and Flonase for allergies used to be prescription, and some of the tummy acid drugs used to be prescription, but they figured out it has this wide therapeutic index. Even going over is fairly safe. Let's make them over the counter. All right, peak trough. Excellent job. You guys rocked these concepts. All right, so where did I want to talk about next chapter here? Oh, you did it. So on the concept of teratogenic effects, I wanted to here. No, we'll go on. We'll talk about it in the next one. So this is, these are all sort of concepts from the first couple of chapters talking about the nursing process, basically, right? It's like you assess and you implement and then you reevaluate. So if you're giving a person a medication for their blood pressure, or a patient is taking a drug for their blood pressure every day, and you're there to give the next dose, what is the most important thing for you to do or implement? And this is typical of NCLEX style, is that they talk about most important. There may be multiple important, but they want you to learn to prioritize what's the most important. So what's the most important thing to do before you give a patient a blood pressure medicine? Yeah, check their blood pressure. If their blood pressure is 70/40, you know, it'd be a good thing maybe to know that before you give them the blood pressure medicine. Smart, right? The nurse is scheduling their peak and trough draw through lab personnel. Oh, you're so lucky, the lab personnel. Let's just say you're doing it. What's the best time to draw the trough? Or what is the best time to have the lab draw the trough? Do you give the dose of the medicine and call the lab to draw the trough stat? Do you arrange for the lab to draw the trough 1 hour after the dose is given? Do you instruct the lab to draw the trough immediately before the next dose? Or do you give the first dose of the medication after the lab reports the trough has been drawn? Yeah. So a lot of people struggle with that. Obviously, the trough is right before the lowest concentration of the drug is right before you take the next dose, right? It's based on onset, peak, and duration. So that's when you're going to draw the trough. So that's another reason you have to know the onset, the peak, and the duration to know when the trough should be drawn. Pretty rational. All right, back to first pass effect. So we said a drug has a high first pass effect. And your prescriber changed the route from by mouth to IV. What do you expect with the IV dose? Is the IV dose higher because of the first pass effect? Is the IV dose lower? IV dose is the same as the PO dose, or the rate of IV infusion has to be faster due to first pass effect? B, right? Because that picture that we drew, that it's already been metabolized when it's PO. If we're slamming it into the bloodstream, it better be the equivalent amount of metabolized drug from the PO route, right, you're giving a much lower dose. Smart, smart people. All right, let's get out of this and let's look at this. So lifespan considerations. There's quite a few things in this chapter that show up on an exams. And it's first is knowing which, obviously, which stages of life affect pharmacokinetics the most. So obviously, if you've got this developing fetus, they have immature organs, poorly developed organs, so they're very susceptible to effects of the drugs that mom takes. Newborn. So what's the age? What's considered a newborn? What's the age range? 0 to a month is a newborn, right? Pediatric is 1 to 12 months. An older adult is considered to be 65 and older. So knowing your age ranges, knowing your definitions of the age ranges, that's in your textbook as well. So we had talked about with the teratogenesis slide about pregnancy. So when is the greatest risk to the fetus for drug-induced developmental damages? Which trimester? First trimester, right? You go back to anatomy and physiology, how rapidly everything is dividing and forming. That's the time when they're at risk for the greatest damage. When is the most of a drug consumed by the mom transferred to the fetus? Which trimester? It's the third trimester. So most of the drug, the baby is getting more of the drug in the third trimester, but the baby has the most damage in the first trimester. Kind of a, you have to look at what the question is asking, because I have seen this concept show up before on exam. So knowing you've obviously got that first trimester one down, but because the baby now has more blood flow, it's larger, more developed, we have this very mature transfer process from mom to baby. It's getting a lot more of the drug in the third trimester. So what has the FDA done to address safety concerns? They say, hey, you know, take it and let us know if your baby is deformed. No clue? Having read chapter 3 and 4. Right, drugs are tested before we ever approve them for use in pregnancy. We can't ethically give a drug to a mom and then wait to see what happens. It's usually in stages. If you've read the chapter about phases of drug investigation, you know, you have to start with theoretical models, and then you start with animal models and working your way up. We'll talk about this thalidomide. Are breastfed infants at risk for exposure through breast milk? For sure. So it's the same idea of looking up drugs. There's going to be a pregnancy and lactation section in your form under special considerations to know whether this is safe or that the risks outweigh the benefits. There are some drugs that mom has to take. Seizure medication, mom needs it. And there are known potential harms to baby, but usually the discussion is, do the risks to the baby or the risks to the mom, which is the priority? That's often a really difficult question. You know, figuring out, no mom wants to expose their child to a risk, but sometimes it's inevitable. Let us look at, let's see, side effects and toxic effects are, yeah. So this is just more of the same thing. So the side and toxic effects of all medications are evaluated on the adult population. So all of our studies are on the adult population because of the ethics of testing on pregnant women and babies. It's very unethical to test on a fetus or a baby that can't give consent to be tested on. So a lot of our dosages and guidelines are our scientific best guess, unfortunately. Yeah. So this is the process that drugs go through. So obviously, you just have to generally know the phases of clinical investigation. The key on this is informed consent. What's informed consent? What's the concept of informed consent?
Do they know what's going on and what they're saying?
Yeah.
Right.
You're
You
aware.
know what the study is about. You know the risks associated. You know that you have the right to withdraw at any time. All studies require informed consent. It's the standard. So back to drug approving. Let's go back here. I wanted to bring up. So back in the 1950s, there was a drug called thalidomide. So this is before the days of rigorous FDA testing. And thalidomide was a drug that was out on the market like a sedative. And then it got used for a whole bunch of other stuff. It got used for sleep and eventually got used for nausea and vomiting by pregnant women. And the drug company decided that it was safe for pregnant women because no matter how much of this drug they gave in the animal model, they couldn't find a fatal dose. So they kept giving higher and higher doses to animals of thalidomide, and the animals did fine. So they said, great, this drug is safe, right? Makes sense. If it doesn't kill an animal, it's safe to you. Well, turns out that it wasn't safe, that moms started having babies with birth defects. But the drug company still said, well, it's not because of us, because look, this child has this defect and this child has a completely different defect. How's that possible? So I want to see if this one will play here. It's kind of an interesting, let's see if that sounds on. Base level 1, that's on. This happened last time. And sorry. Dadgummit. All right. Well, so it ended up, it was going to be a really good one. Too bad I can't get the sound to work.
You should put it on announcements.
Yeah, I can. So what happened was that depends on when you take the medicine, because of the stages of the fetal development, right? If you took it during week or on day 20, you had a different teratogenic effect than on day 23. And so we ended up with a lot of children with birth defects, missing limbs from this drug. So that was one of the biggest impetus. It started in Germany and Europe, and finally, the drug came out and was in America, and then we started putting the pieces all together. So that was in the 50s and early 60s. And so that was really the impetus to say, okay, animal testing is not sufficient. Drug testing, right? We need to come up with better ways to test drugs. And that's why over time, we came up with this far more structured way that drugs go through drug testing. So on the topic of informed consent, I also had a really great video in there, which, about the Tuskegee study. For the people who haven't taken this class, does anybody know about the Tuskegee study? So this is on the concept of informed consent. the US government decided that it wanted to know what happened during the course of syphilis. Just back in the early stages, what happens in the early stages of the disease, the middle stages, and the late stages. And so this Tuskegee study gets its name from the city Tuskegee, where a bunch of African-American men who did not know that they were in a study were followed in their course of syphilis, even when at a point in time where we had an antibiotic for syphilis. So when penicillin was developed. And they went through most of their life into the 1970s, not knowing that they were in a medical study following the course of syphilis. So the ethics of that, pretty questionable, right? That's our own government here saying, you know, you don't have any right to know what we're studying or what we're doing. So I would encourage you to, if you have a chance in a free time, to watch that video. That one is linked in there. It's really discouraging, but it also explains why our drug process is so rigorous and so lengthy. Black box warning. What do we know about black box warning? So over time, usually these really serious adverse events don't show up when before the drug is approved, right? There's still a rigorous drug testing. It takes, what, 10 years on average to get a new drug to market? But all that 10 years isn't with humans. And so what we find over time, it may be 10 years out, is that there are some serious but infrequent effects of the drug. And so these most serious consequences are called black box, right? And it's something that you as the nurse, when you're giving drug education, you need to know when a drug has a black box warning and what that black box warning is, and discuss that with the patient, because that's part of informed consent, right? Your patient has the right to know what is the potential harm of taking this medication. For instance, ciprofloxacin and levofloxacin, Cipro and Levaquip. Anybody ever taken those antibiotics for something super common? Cipro and Levaquip. So they're in a class of antibiotics called fluoroquinolone, and these are where once people started having penicillin resistances, this class of drug came out, we found what they were good for, we started using them a lot. And only many, many years later did we find out that in a small subset of the population, they are at risk for spontaneous tendon rupture. So it's usually in older adults, but it can happen. So it's always good to, I was just telling a patient yesterday in clinic, you know, I have to give them Cipro, and I'm telling them it has a black box warning, which means there's a low frequency of this happening, but if it does happen, it's a very serious side effect. And, you know, you give an example of what that means. If you have sudden weakness in your shoulder or sudden weakness in your ankle, because those are the most common areas affected, you need to stop taking the medicine and seek medical help right away. So you always have to know, we will specifically talk about in medicines, if there has a black box warning, we'll say what that is. You will be expected to know black box warning for any of the drugs that we review. There are quite a few. Yeah, this is the caveat. So I still prescribed this drug. I still prescribed yesterday Cipro, even though it has a black box warning, because it's the only viable antibiotic to treat a Pseudomonas infection. And so I just have to make sure that they're in agreement with taking this. Doesn't mean that you can't take it. Just means you need to educate your patient. Or as a prescriber, you need to be aware of the population and maybe avoid this drug if they're at risk. Black box. We won't name some. All right. So a research group is conducting an investigational drug study on a drug for osteoporosis. it's been hard to find participants who meet all the criteria for this study. So they have finally got enough people, and it was really, really hard to get them. But just before the study ended, 4 of the people said that they wanted to withdraw from the study. So this is again, you talking about what's the priority? What's the priority intervention? You tell them, ah, too bad, so sad, too late. You ask them, what are your reasons for wanting to withdraw? You acknowledge that they can withdraw any time from the study, or request that they try to remain with the study until it's completed. Which is the priority? Right? So this is an example where they give you 2 correct answers, but one is more correct than the other. Of course, you're going to try and find out, but the very first thing a researcher says is that absolutely you have the right to withdraw from the study. Do you mind if I ask a little bit more about your reasons? All right, let's take a 5 to 7 minute break where you can get up and stretch. And then we'll come back and talk about autonomy, beneficence, confidentiality, justice, and non-malfeasance.
Question about the workbook assignments, like on how you can view them. I just took pictures of my phone and submitted it, but they submitted as like JPEGs. Can you still view them that
Yeah,
way?
photos
Okay,
come as
okay,
JPEGs.
I just didn't know, like.
I
some
get
teachers make you,
videos,
like,
I get JPEGs,
convert
I get
it, so-
PDFs, I
Okay.
get.
Okay, I just wanted to make sure, because
Yeah.
I didn't want it to.
If I wasn't able to open it for some reason, and I'm pretty diligent in finding an app that would open it. If I wasn't able to, I would penalize you. I would
Okay.
just ask you to
Okay, I
resubmit
just
it.
wanted to make sure. so-
Yeah.
Okay. sounds
JPEGs
good.
are good.
Thank you.
Oh, it's snowing.
Don't say those.
Oh, okay, it's not.
Evil words, what? I thought I heard rain. Oh, no.
Probably did, but.
You put your backpack in there too?
Not like you carry your like Wilson around that way. I feel like I'm going on a trip.
Yeah, I want to go on that. I'm going to the Bahamas tonight. This is the medium size. They have a smaller and they have a bigger. So I got the medium.
I want to see the bigger
You
one.
have the medium.
This is the medium.
Very interested to see.
Are you doing all your books with you all the time?
Just the pharmacy ones. Just in case. And then two, and then the backpacking. I just felt like I was carrying a t-shirt on both sides. Yeah, what? Four wheels. I know. Slide it around.
Well, here's the problem with the Target by me, is there's the only one.
Always. I was using a suitcase, so I was kind of like, no.
So many people use.
For me, I'm just like, this way, I don't have to unzip it, I can see what's there. It's just like, here you go. Okay.
They'd get treated for their bad blood. Instead, hundreds of poor Black men became they'd get treated for their bad blood. Instead, poor Black men became participants unknowingly in a shocking and truly shameful chapter of American medical history. In 1932, the United States Public Health Service launched an unethical research project to examine the effects of untreated syphilis. The project was called the Tuskegee Study because it recruited 600 Black men living in Tuskegee, Alabama. Researchers told the men that they were being treated for bad blood, a term used locally to describe anything from fatigue to anemia. They promised the men free medical treatment if they participated. While 2/3 of the men in the study were confirmed to have syphilis, not one received proper treatment for the disease they had contracted.
So this was a study in which there was no consent on the part of those who were being studied, also deception on the part of the U.S. government.
When penicillin became the recommended treatment for syphilis in the 1940s, Tuskegee researchers scandalously withheld the drug from the men in the study so that they could continue to chart the course of the disease when untreated. Many patients experienced damage to their vital organs and nervous systems, and for some, the lack of treatment led to death.
The great shame of the study is that the men thought that they were being treated. Treatment was withheld from them, even after it was very clear what kind of medical treatment would cure them of syphilis.
In 1972, an Associated Press article exposed the Tuskegee study after one of the participants brought the story to a civil rights attorney. Only then, after 40 years, was the study brought to an end. The case was settled out of court for $10 million.
This long history of medical experimentation